So how long will your examination typically take? How long does your consultation last for in tertiary care?
45 minutes.
Right, and your examination would take?
No more than I would have thought, about 6 minutes.
Right, quite short.
Yeah.
Yeah, okay. I wonder if we could just finally move on to this big issue of to scan or not to scan, which is something that's at the back of everyone's mind. I mean, first of all, I wonder if you could just say a little bit about modalities, CT, MRI. CT is cheap and cheerful, high radiation, MRI is more accurate. Do you think if you think that someone has got a significant problem, because most of the time we image to reassure patients.
Or ourselves.
Or ourselves, but do you think we should be all doing MRIs? If that case is significant to want further investigation, should it be an MRI or would a CT be okay?
The problem is if you really shouldn't be irradiating people for reassurance. That doesn't seem sensible at some level. I think if we, and the sort of things that you're going to be looking for in a headache examination, with the exclusion of a large brain tumour, and eventually that'll need an MRI at any rate, is MRI. So I think if I have my choice, I very rarely order CTs.
Because they can miss about 10% of tumours, can't they? So I think you're on.
Yeah. And I think the other things we talked about, Arnold-Chiari syndrome, for example, you see that in the SCOUT scan on the MRI, you get it for free, almost. You get, the potential, you very simply draw the end of the line. The thing about imaging for reassurance is the person who needs reassurance is going to read up on the internet that CT doesn't provide him with reassurance. So you'll have spent a few pounds and you'll have irradiated them, and you haven't achieved the goal for either yourself or anyone else. So it's, it's almost a waste of resources, I think, to do something and not even get where you wanted to be.
Certainly in secondary care, the incidence of imaging is going up quite substantially. I guess about 50% of headache referrals are now imaged. I mean, in America, does everyone with a headache get imaged?
Multiple times.
So that's where we're heading to in the UK, do you think? Possibly.
Well, depends on how we deal with it and what we do in the medium to long term. I tell people who haven't had a scan, who've got migraine in a normal examination, that the chance I'm going to find something is no better than doing it in the street. And I point out to them that if they have an image done and there's any odd thing on the inside which is not related, that's going to be written in their medical record from now until the second coming of Christ. That is, it's not going away. And I find certainly among when people think about it a little bit more, think about insurance, think about the implications of someone writing down you've got something in your brain when it's not a problem, that the thinking person shies away a little bit from it because they don't want written down that there's anything going on at all. In the world we live in, the information world we live in, where everything that's written down here is available to everybody. So I've been surprised, but pleasantly surprised, how much the thinking person will then say, well, okay, let's not do that then. The unthinking person still wants their scan, but personally, I see no reason to do, I wouldn't get a scan on myself in that sense, because why would you want a record that there's something happening in your head before you've gone out and got your insurance done? I
mean, I think this is important to put on the table in front of the patient. We've now, certainly in primary care, got some figures to put on that, and I think people like risks. And I mean, as you know, we did a big database study. We looked at 90,000 new headache presentations, followed them up for a year. And if someone sits in front of you in general practice with a headache, their chance of having a tumour is 1 in 1,000. Now, if you're a kid, that goes down by a third. If you're under 18, that goes down to a third of that level. If you're over 50, it's 3 in 1,000. So it gives us a bit of a sort of starting point to start thinking about risk with patients. And I agree with you, the big downside is, and that's why I'm sort of rather pushing against imaging, is that this incidental abnormalities. There was this vomit syndrome that was victim of modern imaging technology that was written up in the BMJ. And I think it's happening more and more. We're all getting these, they're getting increasingly sensitive. And studies are suggesting, there's a meta-analysis in the BMJ, about 3% on average, but some studies are suggesting up to 10%. Incidental abnormalities. And before you know where you are...
I saw a New England Journal study that quoted that figure. And that's frightening 10% is frightening.
Well, there's an interesting study. I just want to sort of share the study of, I don't know if you remember it, 2006. They looked at 2,370 Luftwaffe pilots. These are sort of fit, healthy pilots. Do you know the study? And they all had an MRI as part of their. 93% were thought to be normal, but of those normal people, 25% had variations of the norm, whatever that was. And they had some scary things that I'd never heard of, but they certainly frightened me. 7% of them were abnormal, 56 cysts, 13 vascular abnormalities, 4 adenomas, and in fact 4 tumours. So we're looking at sort of, serious numbers of abnormalities here, and these are normal people that present with not, migraine, and they might be going out of the surgery worried for the rest of their life. They're in front of the neurosurgeon who's giving them all sorts of options, and they become nervous wrecks. So I think unless you really want to know what's inside your brain, unless there's good clinical reason, I would be very reluctant to.
Worst thing than that almost is if the insurance companies wake up to this and start getting you to write that information down on the insurance forms, and they start to factor, do you have something abnormal in your brain into insurance calculations? Yeah, that would bother. That's practically bothersome. So I completely agree with you. I think that we should make imaging really easily available for sensible indications, and defend our colleagues who are not imaging when it's clearly documented that they've done the history and they've done an examination.
I mean, I think that just leaves us just to chat through what are the flags, and I was interested in this business about when is a red flag and not a red flag, because everyone says red flags. Well, what does that actually mean? And I think in the work that you've been involved with through the British Association of Study of Headache, we've rather nailed the fact that a red flag is greater than a 1 in 100 chance of having a tumour. Now that's a bit of an arbitrary, but there is a little bit of evidence to support that. So if you think if there are clinical signs and symptoms to suggest that someone has a headache, have a tumour of more than 1 in 100, then it's worth imaging. And some of those things that might be a red flag, or probably are a red flag, is papilledema or a focal neurological sign, headache with alterations in consciousness, memory, confusion or coordination, and a history of cancer elsewhere we're always looking for. So those are the red flags, which are probably fairly sort of straightforward anyway. The other category we then looked at is orange flags, which need very careful follow-up, where the probability of an underlying tumour is between 0.1 and 1%, as far as we can, on the very limited evidence that's available. These need very careful monitoring and a low threshold for investigation. And these may be where a diagnostic pattern hasn't emerged after 8 weeks. So if you follow the patient up for 8 weeks and you're still unsure, you need to start being a little bit worried. This Valsalva manoeuvre, significant changes in headache pattern, headaches that wake from sleep. These are not red flags, but I think orange flags is a good category. You don't press the button straight away, but you follow them up very, very closely. And then, of course, there are no green flags for headache, because even if they have migraine, you've got to follow them up. So there are orange flags and there are yellow flags. So I think that's quite a useful starting point for the GP.
Yeah, I agree with you. And it's got some data behind it, and of course the management of headache is a little bit like the management of hypertension. You'd never make the diagnosis, put someone on a tablet, send them away and never see them. So setting up an arrangement for follow-up with an expectation you'll continue to that you're going to consider the problem. I think that takes the heat out of the kitchen for many people, because they're kind of afraid that you're going to just send them away and that's the end of it. If you give them a time when you're going to see them again, give them a diary, it's almost therapeutic.
And I think that's why there's such a high rate in secondary care, because they've got the neurologists they've got the one-off hit to get it right, so they have to, whereas in primary care we've got that luxury of bringing patients back weekly if we want to, so I think that's the sort of difference, I think, really.
Okay.
Okay, Peter, I think that's a good place to stop. In our next video we'll be looking at migraine.